So let's kind of turn now to some older cytotoxic chemotherapies. I mean, we talk about all these really exciting and sexy new therapies. And we'll start with nanoparticle paclitaxel. It does have an FDA indication for treatment after failure with combination chemotherapy for metastatic disease or relapse within 6 months of adjuvant chemotherapy. And generally the label says that you had to have had an anthracycline. But HOPE and the CLAGB did a very large trial comparing nanoparticle paclitaxel, ixabepilone, and paclitaxel. And Hope, what's your thoughts on the future of nanoparticle paclitaxel in the post era of the
40503?
Yeah, the post 503.
It hasn't been published yet, but will be soon.
Yeah.
It's an interesting thing because they had done a randomized phase 2 trial in Russia that Bill Gradishar published that looked at one arm was 150 per meter squared of nab-paclitaxel, and they really believed that it was superior to the 100 milligram per meter squared that we were all using, and also to every 3-week dosing it was less toxic, clearly. So that was the arm that they wanted to use in that phase 3 trial. I was never a fan of the high dose, but and of course we hadn't seen the dose response with paclitaxel, and so it's a little bit unclear. Now, what turns out is you just could not deliver that dose. It was just enormously toxic. Ixabepilone at a low dose weekly wasn't so toxic, but wasn't so great either. So, the toxicity with nab-paclitaxel was what caused the problems. There are a number of studies going on now looking at slightly lower dose, 125 per meter squared, in combination with other chemotherapy agents for triple-negative disease that Denise can describe and leads, and then also in the neoadjuvant setting, trying to see whether or not there's a subset that has specific benefit from this drug. But my feeling is it's a great chemotherapy drug. I don't know that we'll find a subset where it works better, and I'm not sure that we're going to find a dose response with higher doses either. I think the dose to go to now outside of a trial is 100 per meter squared and works great, avoids steroids.
Denise, what do you think of that new design for triple-negative disease?
So I think it's very interesting trial in it's looking in the first line triple-negative using the definition of less than 1% ERPR staying HER2 negative, and it's looking at 3 different arms. 2 of the arms have the nab-paclitaxel combined either with carboplatin or gemcitabine, and then the control is gemcitabine carboplatin, really adopted from the Niparib trial where we had data with gem-carbo in a triple-negative population. And so the design of the trial is a 1-to-1-to-1 randomization. It's a phase 2. They'll be collecting tissue for some biomarkers, and they'll go through an algorithm that includes the number of patients that get to cycle 6 of any given arm, the toxicity and obvious efficacy endpoints, and then the plan is to move this into a phase 3 trial against which one of the 2 nab-paclitaxel arms, either with the carbo or gemcitabine, against gem-carbo in a phase 3 design. And hopefully, if the signal is there, I think there would be a plan to get a registration strategy, perhaps in triple negative and also for the weekly schedule. So I think they're looking at both of those. I think one of the things I've also been intrigued with nab-paclitaxel is some of that SPARC data. And I know one of my colleagues, Dr. Infante, had done some work in the pancreatic. We've done some in the neoadjuvant, and I think part of it's been plagued by the assay of trying to get that as a reproducible. There is some interesting data that triple-negative tumors may have a higher SPARC expression, and whether that may play a role in this trial. We'll be interested. Right now, that's not a biomarker that's been selected yet, but I think there's a lot of data out there.
And so another drug that I think has a lot of interest in it is Eribulin. And Eribulin is indicated for patients who have actually received several, at least 2 types of anti-cancer therapy for metastatic breast cancer. And the previous therapy, at least according to the label, should be anthracyclines and taxanes. And so this is a very interesting design. I think a lot of us really like this kind of design, which was in women with at least 2 or 3 regimens. I think the median in the particular trial Embrace was, I think, 3 to 4 regimens for metastatic disease, and received either Eribulin or a physician's choice of therapy. And there was a clear survival benefit to the Eribulin. Interestingly enough, there wasn't really much of a progression-free survival benefit. It was all an overall survival benefit. And so, Kim, I mean, how do you use Eribulin in your practice now?
Yeah, so I think one of the main positive points about Eribulin is that it's fairly easy to give, and it's actually fairly easy to take from a patient perspective, and especially if you're utilizing it in patients who have seen prior taxanes and maybe some other things that require longer infusion times. A 5-minute infusion is a real selling point to patients. And we have 2 large phase 3 studies that show that this drug works in treatment refractory patients and then also in the first-line setting. So Embrace demonstrated a survival benefit, which is hard to argue with in patients who had progressed on multiple lines of therapy. And then we also have the first-line data looking at the Eribulin in comparing it to capecitabine. And that was an equivalence study, meaning that the outcome for Eribulin was equivalent to capecitabine. But there were some interesting subgroup analysis, including the triple-negative subgroup, where it looks like Eribulin might have a little bit more of a benefit over capecitabine. So this is a drug I'm using quite a bit in a number of lines of setting based on its proven efficacy on those 2 studies. You have to watch out for neuropathy and neutropenia, but in general, if you just have to pull a standard chemo off the shelf, this is a pretty well tolerated, and I've seen good efficacy in my patient population.
Other comments about Eribulin?
I think, there's a big learning curve with every drug we use, and I was just saying that to people when they were talking about everolimus, that Eribulin is a good comparator because when we first started using it, in these late-line patients, you got a lot of neutropenia, neutropenic fever. I had one patient with mucositis, and now I don't see any of that because, we sort of liberally sprinkle them with growth factors or dose reduce, mostly growth factors, second growth dose reduce, and I think probably everybody does. I mean, it almost seems as though you can't get somebody through many cycles of Eribulin without growth factors. So that learning curve has really enhanced my use of the drug, and it is extremely well tolerated.
It's been combined with Herceptin too. I think Linda Vidot had presented that data, and I've used it in that setting as well, and it's very active and well tolerated.